So here we go. The next talk is about diabetes. Title of the talk, essentially manage it or reverse it, because they are very different ideas. There's a lot of history behind this talk. And I'll tell you a little bit about my history and who I am and why this has become important for me enough to actually sit up here and discuss this publicly. So my training is in orthopedic surgery. I'm a board certified, fellowship trained orthopedic surgeon. Foot and ankle is my subspecialty. I obviously see a lot of patients with diabetes. I see a lot of the complications from diabetes. And working with Dr. Ashley Lucas and sending my patients to the PhD program, I have seen tremendous turnaround that is unexpected based on my medical training. I'll go through some of the descriptions and the definitions of diabetes. But us as physicians in general, we're taught that diabetes is not reversible. We're taught that it's progressive. And essentially, we just manage the complications and prescribe medications. And so I was very pleased to start seeing some of the patients come back and be off of all their medications and, pain gone or improved and not needing surgery. And so something that encouraged me to look into it further. And this talk is a result of that research. So some disclaimers. When I talk about diabetes, I mention it by itself in here. I'm referring, unless I specifically say otherwise, I'm referring to type 2 diabetes, and I'll discuss what that means compared to type 1. Me giving this talk does not present to us any physician-patient relationship. This is purely for information purposes only, and what you do with it has to be between you and your physician. I'm not making any individual recommendations. If you want to take any of the advice in here, I strongly recommend that you talk to your physician about it prior to changing any of your medications, because there are implications outside of this talk that you would certainly need to discuss with them. From the nutritional side, there are nutrition professionals available. Obviously, PhD is a program that I like, but there are other nutrition professionals available in the communities that these talks are being given in. All right, so here's the definition of diabetes that I wanted to start with. So this is a medical definition, and it says that type 2 diabetes is a progressive disease in which the risks of myocardial infarction, that's heart attack, stroke, microvascular events, and mortality, that's death, are all strongly associated with hyperglycemia, that's high blood glucose. The disease course is primarily characterized by a decline in beta cell function, those are cells in the pancreas that make insulin, and worsening of insulin resistance. The process is manifested clinically by deteriorations in multiple parameters, including A1C, fasting plasma glucose, and postprandial glucose levels. So that's kind of the typical, the typical medical definition that I see. And I don't really love that definition because it doesn't do much to talk about the fact that it's actually really a nutritional problem. The medical side of it is more of how to manage the complications and the morbidity of being diabetic, not so much about the diabetes itself. So my recommendation would be a much more simple definition that says that diabetes, type 2, is a potentially reversible nutritional condition characterized by high levels of blood glucose and insulin. Simply that. And I put in there the U-term permitted because the research that I've done really shows that there are clinics out there, including PhD, that are able to help people turn their diabetes around and get off of all of their medications. And if not all of them, then at least off of some of them, or at least off of insulin. And so it is something that can be made better with the proper nutritional approach. All right, so a little history about diabetes. Diabetes has been known in the medical community for centuries. There are recordings of it from hundreds of years ago, thousands of years ago, where they talk about people with sweet tasting urine and a disease that people get sick from very, very quickly. But in the United States, it didn't really come to be in the medical literature until Dr. Jocelyn, as a medical student in 1893, researched it within his, within Mass General Hospital, and found a prevalence of 0.3% within that inpatient population. And here we are now in 2015, the estimated rates are 14.3% of American population is diabetic and 38% is pre-diabetic. That means that the sum of those two together are the majority of our population, and that the majority of our population is pre-diabetic or diabetic. with a cost of estimated $327 billion in 2017. So here's the difference between type 1 and type 2 diabetes. Type 1 diabetes is where your body does not produce enough insulin. So your insulin levels are low, but your blood glucose levels are high. We'll talk about what that means. But essentially, insulin levels are low, blood glucose levels are high. Different from type 2 diabetes, where your insulin levels are high and your blood glucose levels are high, and the treatment should be aimed at something other than where it probably currently is. But the big difference between them is the type 1 diabetics do not make enough insulin, and type 2 diabetics start out not making enough insulin, but they already have high levels of insulin, and then they can eventually not make enough insulin and require insulin under the current treatment paradigm. So if we look at why diabetes is a big deal, if the numbers I just said weren't important enough, here's diabetes listed at number 7 in the top 10 causes of death in the United States in 2016 and 2017. And you say, well, it's number 7, it's not that bad. But the reality is that diabetes is associated with heart disease and kidney disease and stroke and cancer and probably dementia and Alzheimer's disease. So really, it is a part of 6 of the top 10 top causes of death in the United States, not to mention the disease associated with it. We call it progressive within the medical community because statistically it is. After 9 years, less than a quarter of the people that are type 2 diabetics will be able to control their blood glucose with only 1 pill. That's not even talking about lifestyle treatment. After 10 to 15 years, over 50% of patients will require insulin to keep their blood sugar levels at goal. And we'll take a step back from diabetes and look at something else that has risen just as quickly, almost in step with diabetes, and that's obesity. So I'm not saying that all obese people are diabetic or all diabetics are obese, but there certainly is an association between the two, and it should be looked at as such. If you look at this graph, you can see that right here, between 1976 and 1980, something changed. And if you think about the current paradigm that everybody's heard that the cure of obesity is to move more and eat less, then apparently around 1977, we all decided to start eating more and be lazy. And I have a hard time believing that that's true. And I will propose a theory that says that that's not true. This is actually what happened in 1977. The food guide pyramid came out. Prior to that, it was the 4 squares of food items, and now is the food guide pyramid. And you can see on the bottom there that you have 6 to 11 servings of bread, cereal, rice, pasta. And on the top, you can see fats, oils, and sweets used sparingly. So that happened in 1977. And this is where we are in 2016. And these are self-reported rates of obesity, but you can appreciate that those numbers are very, very high. And kudos to Colorado for being the lone green state in there, I guess, except for Massachusetts. So why is it important to talk about obesity and diabetes? Well, as I mentioned, they did rise in step with each other. There was actually a study in 1990, I'm sorry, it wasn't a study, it was a report in the Dietary Guidelines Advisory Committee that suggested that weight gain after the age of 18 was consistent with good health. And this was sort of, everybody knew that after 18, you're going to put on a little weight around your midsection, and that's okay. That means you're eating well and you're healthy. Dr. Willett, who is an associate, he is a professor at Harvard in the epidemiology and nutrition department, published a study that demonstrated that weight gain, if you look at it, around 15 pounds, increases your risk of type 2 diabetes by 90%. And if you go up to 24 pounds, by 270%. So his suggestion was that extra weight gain after the age of 18 was probably not benign, and that we should look at this a little bit closer. So I mentioned insulin before. I didn't really talk about what it is or what it does, and it requires a little bit of explanation. So insulin is a hormone. It is a hormone that causes things to be stored. It is the storage hormone, and it is very, very powerful. Most hormones do the opposite of insulin. Most hormones will cause energy to be released from cells so that your body can do whatever it is that the hormone wants it to be done. So whether it be a thyroid or whether it be something coming from the adrenal glands. But insulin is a storage hormone. And we'll talk kind of why insulin is secreted. The negative feedback of insulin being removed is actually what is required for energy to flow out of fat cells. So again, insulin has to be gone for fat cells to burn fat and make energy. So what happens to insulin when we eat? Well, we all know there's three basic macronutrient groups, right? There's carbohydrates that can be processed effectively by the liver. It can raise blood glucose. And if it raises blood glucose, it's because you probably eaten too much of it and you don't have a place to put it. Dietary fat, on the other hand, is actually going to raise neither insulin or blood glucose. So when you consume insulin, you get uptake of glucose into your cells. So insulin pours it in the bloodstream, and it takes the blood glucose, that sugar in your blood, and it forces it into your cells. It tells your liver to go into a fed state and encourages storage. So glucose becomes glycogen. Amino acids can become, that's amino acids from protein, can become glucose, which is sugar, which is then stored as glycogen. Once the glycogen is full, then you go through what's called de novo lipogenesis, which means that you start making fat out of all of those things that you just consumed with the protein and the glucose. So that fat is then produced on, that fat is then put on a protein backbone. It's made called a triglyceride. You've heard that term. You're talking about cholesterol. Triglycerides, again, are made from carbohydrates or protein when overconsumed. And those go into the VLDL and are pushed out into the bloodstream, and they're stored in adipocytes or fat cells. And that's how your body stores extra protein and carbohydrate. And again, you do not have a lot of glycogen stored in your liver, so this happens relatively quickly. So how do you make that insulin level go down? Well, you stop eating. So if you stop eating, your blood glucose level will drop. Your insulin level will drop as a result of that. And then you start breaking down glycogen. You basically reverse what you did when you were eating. So glycogen gets broken down, and then you undergo what's called gluconeogenesis, which means that you're breaking down fat and you're putting energy, you're pulling energy out of your fat cells and then putting them into your mitochondria to make energy. And so that's how you actually burn fat. So I'm going to try to describe an analogy here that I think helps people to understand what's actually going on with diabetes. So your body under normal circumstances will consume carbohydrates, puts it either into the liver or pushes it out into the fat cells if you overeat it. But your body also, when you consume carbohydrates, those sugars, as they're broken down, will go directly into the bloodstream, and your cells take those up as well. Your cells can get full of sugar if they're not allowed to burn enough sugar in the process of this. And so once those cells start to fill up, it's like a suitcase that's too full of clothing. It's like we've tried to put too much clothing into our suitcase. You just can't you can't get the lid closed. But if you keep eating carbohydrates, then you have more clothes or sugar to put into the suitcase. So what do? Well, you start shoving clothes into the suitcase, and your body does that by continuing to increase your insulin levels, because insulin is the tool to get things into your suitcase or into your cell. And so you can think of diabetes as being the condition where the suitcase is full, we're trying to get more clothes into the suitcase, but we ultimately can't get any more clothes into the suitcase or sugar into the cell. And so when you're trying to do this, your body says, all right, well, I'm going to just increase more insulin, and insulin is my strong guy, and I'm going to get all of that sugar into your cell. And it can do that for a little bit, but then you have more blood sugar and you haven't burned off any in your cell. And so then you get another insulin rise, you get another bump of insulin. And then when that's not enough, then your doctor prescribes an oral pill. So you're taking a pill for your diabetes on top of having high levels of insulin. And then you might have another pill if that's not enough. And then you might have to take exogenous insulin or injections of insulin. So you have all of this power trying to get sugar into the cell, but the cell is already full. And so I like to call diabetes an overflow phenomenon. And I totally stole this from Dr. Jason Fung. But it's an overflow phenomenon where there's just too much sugar in the cell. The cell can no longer take any more. I mean, we're just trying harder and harder with our current treatment paradigm to put more sugar into the cell. And you can see this clearly in these studies looking at fasting insulin levels. So if you look down here at the bottom on the left, non-diabetic lean people have normal but low levels of insulin. Non-diabetic obese people are going to have significantly higher insulin, and then pre-diabetic obese people, it's even higher, and then diabetic obese, it's even higher. So these are fasting levels, which are relatively easy to measure, but insulin as a hormone is up and down, and so the average is relatively difficult to get, and that's why when your doctor doesn't say, well, we'll just test your insulin level, it's kind of hard to measure, and if you see a low number, it doesn't necessarily mean that you don't have high insulin levels. So hormones are difficult to measure for that reason. So insulin resistance, as you heard me mention in the diabetes definition, insulin resistance occurs because insulin is one of the few hormones that we have conscious control over when it is secreted to some extent. Most hormones are pulsed. So your brain will identify that you have a need in your body, your brain will secrete a hormone, your cells pick up on it, it does whatever it needs to do, and then the hormone goes away. And by pulsing hormones, your cells are always going to be sensitive to it. Insulin, though, if you eat a state of chronic feeding where you're eating all the time, or if you eat a high carbohydrate diet and you're not tolerant to it, your insulin level is always high. So we control when our insulin is being excreted by our pancreas by what we're consuming, at least initially, and you can create what's called insulin resistance. So as I mentioned, low-fat diets, particularly low-fat diets with a recommendation to eat every 2 or 3 hours to help contain hunger, you're constantly increasing your level of insulin. Insulin, when it's always present, the cells, the receivers of the insulin, the receptors, will eventually kind of wear out, or they'll produce more, but they don't have enough, and they become resistant to the level of insulin that's in the bloodstream. And we know this is true if we look at certain pathologic conditions. So an insulinoma is a tumor, it's a benign tumor, it's not necessarily true, but it's a tumor, and it secretes insulin. And what happens when you have an insulinoma is that you gain weight and your blood sugar goes down. And you know that this is true if you take a sulfonylurea drug, which is a diabetes pill, and that causes insulin to be secreted by your pancreas to help lower your blood glucose. And it does lower your blood glucose, but it causes weight gain because it's making your insulin levels higher. And another class of drugs called TZDs, so these also increase insulin secondarily by increasing sensitivity to insulin, and it results in weight gain and decreased blood sugar. So we know that the response to insulin is going to be relatively predictable. And if we have it there all the time, then you would expect to see weight gain and lower blood sugar until your diabetes gets worse and your blood sugar continues to go up. So if we go back to that overflow phenomenon and compare it with insulin resistance, you could say, well, if you have chronic levels of insulin, then you're going to develop insulin resistance. And is that a testable thing? And the answer is yes, that is a testable thing. So there's 2 studies cited here. One is a study where they infused a low level of insulin for 40 hours, and then they tested insulin resistance. And you can test insulin resistance, but I've read the description of it, and it doesn't sound like anything that I would put anybody through. But it is testable, and so in these patients, they did this, and after just 40 hours, you can see a 15% increase in resistance. After 96 hours, you saw up to a 40% increase in resistance. So imagine if you're talking about decades of having high levels of insulin, imagine what your insulin resistance is like. And this has actually been borne out in a new model of obesity called the carbohydrate insulin model of obesity, which has been published recently. I believe this was from last year, from 2018. And it basically says that carbohydrate consumption and high levels of insulin are the cause of obesity, unlike what the current model is, which I'll talk in depth about here in a minute. So if you think, well, why is insulin resistance such a big deal? Well, it's a big deal because of what it's associated with. So metabolic syndrome, you've most likely heard of it. The metabolic syndrome is defined as any 3 of the 5 conditions listed here. 2 of them are in the abnormal cholesterol with high triglycerides and low HDL. Metabolic syndrome is associated with increased risk of heart disease, stroke, and diabetes. And all of those things are demonstrated to be associated with insulin resistance. Again, to go back to the top 10 causes of death in the US, heart disease, diabetes, cancer, stroke, dementia, all of them associated with insulin resistance. So it is a big deal. The guiding principles for diabetes, and this I believe is a 2018 publication, and this is endorsed by everybody from family practice, college to endocrinology to American College of Cardiology, American Heart Association, NIH, and also it's the American Academy of Family Physicians. But they all endorse these guiding principles, and the guiding principles are based on the concept of lowering blood glucose. And they start out with lifestyle recommendations, which I completely agree with. And the American Diabetes Association defines this as focusing on diet, physical activity, and behavioral strategies to achieve a 500 to 750 kilocalorie per day energy deficit. So you say, well, wait a minute, when did we start talking about calorie deficits? That sounds like it's going to make me hungry. If that doesn't do it, then oral medications and insulin are then prescribed. So the ADA has a very nice website that has some nice suggestions and menu options and descriptions of food, and it is a very nice website. The USDA has the choosemyplate.gov that talks about the new dietary guidelines for Americans that came out in 2015 with all the same recommendations. And they're all based off of the energy balance hypothesis. So the energy balance hypothesis says that obesity results from eating too much and exercising too little. Essentially, too many calories coming in, not enough calories being taken out. And the first law of thermodynamics has been invoked to help explain this. And this is, by definition, the law of the conservation of energy, which says that the total energy of a system is constant, and that energy cannot be created nor destroyed. And I am not arguing that that's not true. They then extrapolate on that to say that a calorie is a calorie, and it makes no difference what that calorie is. And just at first glance, you think, so if I have 100 calories of a Twinkie, that's the same as 100 calories of spinach. And it just doesn't sound right. And I'll go through why I think that that's not right. So the energy balance hypothesis versus the hormonal hypothesis. And to be clear, the hormonal hypothesis is the carbohydrate insulin theory of obesity. So this is actually what the first law of thermodynamics looks like. And it says, again, that a change in internal energy, by definition of a closed system, equals the amount of heat supplied. Okay, yeah, that's calories in, minus work done. That does sound like exercise. So I agree that the nutritional version of that is body equals calories consumed minus calories expended. But the problem with that is it assumes that calories consumed and calories expended are independent variables, meaning that one does not change the other. And it also assumes that the body is actually constant, and therefore that a positive energy balance would result in obesity. So let's consider a couple of hormonal things, think about how that makes sense. So what about child growth? I have a 6-year-old and a 5-year-old and a 6-week-old. They're all growing like crazy. And so if you were to apply this definition, you could say, well, the Q, the calories in, or the amount of heat supplied, is going to result in them changing their body. So what you're telling me is that the amount of food that my 6-year-old eats is going to result in him getting taller. And I would argue that there's probably something going on in his body that is going to result in him being hungry. He's going to eat more food. And I can tell you that also is going to work out a lot more. He's going to run around like crazy. So it's probably something on the other side of the equal sign, hormonally driven, that is resulting in him eating more food. And if you look at it the other way, you say, well, what about the other side? And you can work out. So if I make him run around more than he wants to, is he going to grow less? Probably not. Maybe. Probably not. What about exercise? What if we just look at exercise in general and we say, well, because I don't run, if I start training for a marathon, am I going to lose weight? And I can tell you for me that the answer is no. I would be so hungry if I tried to run that far and my knees would hurt that I would eat a lot of food and I would very definitely gain weight. And there was actually a study that looked at that and recruited a bunch of college students and paid them to train for a marathon. And their average weight loss was positive. They actually gained weight because they are not independent variables. They're dependent variables. And if you change one, you will change another and likely change another. So I'd like to redefine that to say changes in the body equal hunger minus BMR, which is basal metabolic rate. That's the amount of calories your body needs just to be you and do nothing else, plus exercise, plus what you're excreting, because we can excrete things that have energy in them. And I would argue that of all those things that I just put up there, you have conscious control over pretty much none of them. Maybe a little bit exercise, but changes in your body are going to be hormonally driven. Hunger is hormonally driven. Your basal metabolic rate is hormonally driven. Exercise, you may have some willpower and conscious control over, but your body will respond and you will feel either like exercising or not. And then you have no control over what comes out of your body typically. And so if we look at the dietary guidelines, again, they were established in 1977. That's where that curve kind of went up with obesity. And from 1977 until 2015, the recommendation for what to eat from a macronutrient standpoint was 60% carbohydrate, 30% protein, and 10% dietary fat. That 10% was actually erased in 2015, and the new guidelines say eat an unrestricted amount of healthy fat, but limit your calories to 1,200 to 1,500 calories per day and exercise. I believe it's 175 minutes a week. The fat was taken out, the fat restriction was taken out based on some very well done studies, two of which, the Nurses' Health Study and the Women's Health Initiative, which demonstrated no relationship between dietary fat and heart disease or stroke. Unfortunately, also in those studies where they were trying to exercise and eat well to lose weight, they did not lose weight. And they found that of the groups that exercised a lot versus a little, there was no association between exercise and weight loss. So some interesting studies that brought up a whole bunch of questions that I think we have at least answered from a clinical standpoint. From a diabetic perspective, the 2012 randomized control trial called the Look Ahead trial or Look Ahead cohort. This is a busy slide, I apologize. But what I want to point out is this. So this is your diabetic support and education intervention. This is your standard diabetes education. There were 3 group sessions per year. They recommended diet, activity, and social support for people to lose weight and hopefully go into remission. And their definition of remission was a fasting blood glucose less than 126, an A1C less than 6.5, and no oral hypoglycemic pills. And if you look at their weight loss success in that group, it was 0.8%. That's less than 1% of weight loss after a year, and that was marginally maintained at 4 years. If you look at remission with that recommendation, 2% of those people were able to go into remission, and that was not maintained, and is less than 1% at 4 years. So that recommendation did not really seem to have a tremendous effect for those with diabetes. And if you look at other studies where the design was based off of energy balance, particularly the Women's Health Initiative. This was the details a little bit. It's a randomized trial, 50,000 women, huge study, hundreds of millions of dollars. And in the intervention arm, they recommended calorie reduction, which averaged about 342 calories, increased activity by 10%. The expected weight loss with that calorie reduction, if a calorie is a calorie, is 32 pounds per year. After 7 years, average weight loss was 0 pounds. How frustrating. A study in 2015 of 175,000 medical records of the health system in California looked at people that were listed as obese with recommendations made by their doctors to lose weight. And they demonstrated that of those 175,000 people, if you had a BMI of 30 to 39, less than 1% of men were able to get back to normal body weight, and almost 1% of women were able to get to normal body weight. And if your BMI was over 40, then it was less than 0.1% for men and 0.2% for women. So something that obviously isn't right. And if you say, well, gosh, I saw this show where they lost a ton of weight, and I know that they didn't eat very much and they exercised all the time. And you're right. So there is a really nice study looking at contestants at The Biggest Loser. Their diet was very clearly published and publicized, and the recommended diet for The Biggest Loser was a 1,200 to 1,500 calorie diet. Sounds very familiar. They exercised, though, 120 minutes a day, not a week. So that's a lot of exercise, and they did lose weight. They lost 120 pounds over 6 months on average. Unfortunately, their basal metabolic rate, meaning the number of calories that your body burns just being you, just waking up and living, that basal metabolic rate, and again for women, this could be around 1,500 calories, maybe 2,000 calories if you have a lot of muscle mass. For men, 2,500 calories. Their average basal metabolic rate dropped by almost 800 calories a day after they were done. And if you think about that, when it comes to a maintenance standpoint, that seems nearly impossible to overcome, to consume 800 calories less than you did before you started the diet on a regular basis. And you say, well, didn't it just come right back? Well, no, actually it didn't. So this is what they published, is that 6 years after they finished the program, their BMR had not recovered. So their basal metabolic rate 6 years later did not recover from that starvation mode. So starvation. A lot of people are absolutely afraid of starvation, and you should be, because the effects of starvation are very bad. But I want to be very clear that starvation is not the same thing as fasting. Starvation and fasting are two different things. Starvation is reduced calorie intake on a regular basis. And this is studied, actually published back in 1951 by Dr. Ansel Keys himself. And they studied this in the late 40s because a lot of people in a number of countries after World War II were starving. They didn't really know what the physiologic effect of starving was. And so they tried to find 150-pound average height men with average muscle mass, and they put them on a 1,500 calorie diet. Your average loss was a little over 30 pounds. Their calculated loss during the study should have been almost 80 pounds. So again, calorie, not necessarily a calorie, but their basal metabolic rate was reduced by 30%. Their complaints during the study, they were cold, they were tired, they were hungry, they had cravings, and they expressed some concern about psychological disorders. They couldn't think. A lot of them had to drop out of educational programs or not go into work because they just couldn't focus. And then upon returning to normal eating, they gained all their weight back and more. Sound familiar? And so the deal with starvation is that if your basal metabolic rate drops and you eventually, your weight will plateau, your weight loss will plateau, then you'll have to reduce the amount of calories that you consume even more, and your basal metabolic rate will drop a little bit more. And it's a downward spiral, and you get to a point where you're no longer able to tolerate the calories that you're consuming, and then you go back to the way you're eating, and then you gain your weight back. All right, so lifestyle recommendations that are out there right now, I feel like are not really working very well. So let's look at the medical treatment, because it actually gives us, I think, some good information on where we should be focusing from a nutrition and lifestyle standpoint. So insulin. The studies that looked at insulin for type 1 diabetics were amazing. Type 1 diabetes prior to the development of insulin was a fatal condition, and it killed patients very, very quickly. It's horrible. Once you were able to give people insulin, then you were able to keep them alive, and now the lifespan is, I believe, I'm misquoting, I believe it is near normal, if not normal. So the benefits of insulin are that you decrease the retinopathy and the nephropathy and the neuropathy, so all the more comorbidities associated with diabetes. However, when you give someone a lot of insulin, no surprise that you develop obesity and metabolic syndrome, and you develop coronary artery disease or atherosclerosis. And so they came up with this term called double diabetes, which is basically people that have type 1 diabetes that have been treated with insulin that then develop all the problems of type 2 diabetes. And so you're really trading glucotoxicity, which is high levels of blood glucose, for hyperinsulinemia or insulin toxicity. But the recommendations for type 2 were really the same as those for type 1. But the problem is they don't really seem to be the same disease. And so there was a study that looked at the effects of this lifestyle or this medical intervention in type 2 diabetics. And this was a study of 4,000 patients over 10 years. And the intervention was insulin if they needed it, oral medications. We'll talk about the different classifications there. And in the intervention group, they saw a weight gain, which again is no surprise. But they didn't see any improvement in coronary artery disease. They did see a small improvement in retinopathy as a result likely of lowering blood glucose, which is a little bit concerning because that's really what we're worried about, is preventing the comorbidities from killing people with diabetes. Another study called the ACCORD study, 10,000 type 2 diabetics, and these are at-risk diabetics. These are relatively sick individuals. And there were two arms to this study: intensive treatment, where the recommended A1C goal was less than 6, which is pretty tight blood glucose control, versus conventional, where the A1C is less than 8. And early on in the study, they recognized that there was a higher all-cause mortality in the intervention group of tight control. And so that intensive arm was canceled, and everybody else had the recommendation of less tight blood glucose control. Other studies, the advanced study, the Origin, the VAT, they all failed to demonstrate improved outcomes with tight glucose control. And it left people scratching their heads, because if you're getting your blood glucose down, you shouldn't see all the complications of diabetes. But the problem is, you might be looking at the wrong target. So this study called the EuroDiab study, published in 2008, looked at complications from diabetes and tried to identify factors that were associated with having those complications. And as it turns out, people that had higher levels of A1C, the glucotoxicity didn't really seem to correlate with having complications. But what did is the hip to waist ratio, which is a sign of metabolic syndrome, which is the only marker of metabolic syndrome that they measured. Another study published in 2003 looked at type 1 diabetics, 400 type 1 diabetics that had survived for over 50 years with the disease. So these are people where you would say, all right, I think that these patients must have had good glucose control if they were able to survive that long. But the reality is that their A1C was around 8 or 9. I believe the average was between 8 and 9. So that is not very good glucose control. But what they did have consistently was low requirements of insulin. And so their insulin dose was low. They did not have hyperinsulinemia. So this is an observational study, and you have to look at observational studies for what they're worth. But this was an observational study that showed that type 2 diabetics that were exposed to insulin and their treatment had an increased risk of cardiovascular event up to 53%. And that's of mortality, actually, not just events. And that's concerning because 1/3 of the diabetics in the US are using insulin. But again, these are observational studies that show associations, not causation. But a study that shows an association should at least be used to make a new hypothesis that we should study to say, okay, well, this might be true. My hypothesis is that maybe insulin is the problem. And let's look and see if we can prove that insulin is really the cause of all this morbidity and not so much the glucose. Not saying that glucose isn't toxic, because it is, but it's not the whole picture. So I want to go through the hypoglycemic drugs or the oral medications for diabetes, just because, again, it helps us to determine what is the appropriate lifestyle path. And so these drugs is a tremendously big class of drugs. Insulin and the oral medications together were a $23 billion market in 2015. They work by targeting various things, and which is actually why they're so interesting. And I like to group them by either medications that cause weight gain or weight loss, insulin up or no change in insulin or insulin down, and if they have any effect on sugar toxicity. So the first one we talk about is metformin. It is one of the most common drugs to be on for diabetes, and if you're pre-diabetic, probably you're put on metformin. It works by blocking new blood sugar production or new glucose from fat. It does not really change insulin levels. It does improve your blood glucose, and it does improve morbidity. So this is a reasonable drug, but it doesn't really change the level of glucose in the cell. So intracellular glucose doesn't change, and it doesn't reverse diabetes, but it is a reasonable way to treat it from an oral standpoint. Sulfonylureas, the SUs, these are brand names, glyburide, glucoside. So these stimulate the pancreas to secrete more insulin. So obviously it increases your insulin level, and it causes weight gain as a result. It will improve your blood glucose, but it does increase insulin. There's some thought that it has a higher rate of cardiovascular events when compared to metformin, which is a little bit concerning, but the weight gain is what was most concerning. TZDs, so this is Avandia Actos. So this is the one that increases insulin sensitivity, which kind of secondarily increases insulin, but it really doesn't change your insulin level, but it does cause weight gain because your fat cells are more sensitive to insulin. This was associated with an increased risk of heart attack and bladder cancer, so that has lost popularity. The DPP-4 inhibitors, so this is Januvia. So Januvia doesn't have an effect on insulin. It works through a different hormonal pathway, and it causes insulin to kind of pulse up and down. And as a result of that, it will improve blood glucose. It doesn't change your average insulin level or your fasting insulin level. And the studies looking at the outcomes of this showed no increase in heart attack or stroke. Also showed no reduction in heart attack or stroke, but it does reduce your A1C, and therefore it was a big seller. And in 2015, it raked in almost $3.9 billion. The SGLT2 inhibitors is a drug, one of the few drugs that will actually lower insulin as well as your A1C, your blood glucose, and it blocks glucose from being reabsorbed back from the kidneys. It will lower insulin and therefore will result in weight loss, improved blood pressure, improved markers of arterial stiffness. The study behind that looked and demonstrated a reduced risk of death by 38%, reduced progression of kidney disease by 40%, and reduced need for dialysis by 55%. The A1C actually didn't improve that much. So this is typically given in addition to other drugs, but it does result in weight loss. It has the side effects of UTI and ketoacidosis, but the ketoacidosis is pretty darn rare with this drug. So this is a drug, again, that lowers insulin. And if I had to pick a drug to be on, I'd probably pick this one. Alpha glucosidase inhibitors, I put these in here really just for completion's sake. These aren't popular in the United States. The GLP-1 peptides, Victoza, not prescribed as frequently because of nausea and vomiting. And then there's bariatric surgery. So bariatric surgery as a surgeon is a really interesting topic. And it is so effective in some ways that it is recognized in this position statement as that metabolic surgery is a standard treatment option for type 2 diabetes. And there's a whole lot of caveats to that, but it is recognized as being very, very effective. Excuse me. So bariatric surgery can improve diabetes. It certainly does result in weight loss. This particular study that I pointed out here, 40% improvement in diabetes control after 1 year, and many of those people actually did achieve remission. So it does work, but it comes at a cost. So 3 years post-op, another study showed a 63% risk of anemia, 33% risk of B12 deficiency, weight gain comes back up to 50% in some studies. And then you have potential surgical complications, which as a surgeon, I know they don't happen that often, but when they do happen, particularly in bariatric surgery, they can be really profound. So it's an interesting study I ran across as I was looking at bariatric surgery. And this is a study where they looked at an inpatient calorie restrictive alternating with fasting diet prior to having bariatric surgery, and then followed the patients post-operatively. My complaint about the study is that neither of those interventions were very long, but it was interesting to me that the recommendations from the study were that the weight loss, the glycemic control, and the loss of central obesity was actually superior in the fat and the nutrition side. And their conclusion was that the diet-only intervention was superior to surgical intervention, which I thought was a peculiar statement from a surgical study. But if you think of how do we cure diabetes? Well, again, it goes back to that overflow phenomenon. And whether you stop putting sugar in as a result of bariatric surgery, or you stop doing it as a result of nutrition, the end result needs to be the same. And so the two principles of curing diabetes is that, number one, consider it as a nutritional disorder and stop putting sugar in and burn off what's left. And so if you think of diabetes, again, as an overflow phenomenon, if you want to switch from the suitcase to a sink with the faucet on, if your faucet is on and your sink is overflowing, exercise is going to basically be, kind of widening the output a little bit. We're going to make the drain a little bit bigger. But the significance of exercise has likely been overstated historically. Medications like insulin and oral hypoglycemics are all just trying to mop things up and put them back in the sink. But ultimately what we need to do is turn off the faucet. You need to stop the sugar from coming in and then deal with whatever is left over. So what do we do nutritionally to deal with what's left over? Well, carbohydrate restriction, or understanding your carbohydrate tolerance, meal timing, not necessarily eating every 2 hours, so you're continuing to bump your insulin up and up and up. Exercise, to some extent, is helpful, and fasting, which is not starvation. So this isn't really new. The Joslin Diabetes Center, again, going way back to slide number 3, Dr. Joslin created a tremendous career with diabetes. And the Diabetes Center that he created has helped people with diabetes for, I don't know how long it's been open, but for decades at least. And in 2005, they adopted a carbohydrate restricted diet. And since that time, they published that they've lost over 10,000 pounds on their patients and are in the business of reversing diabetes with that diet. There's a group out of Indiana called Verda. They published some nice studies looking at carbohydrate restriction. And this was a study of 262 patients. And these are diabetic patients. And they demonstrated that with this carbohydrate restriction, they had 0% ketoacidosis. So nobody went into ketoacidosis. 12% body weight loss, so much higher than anything else that we've seen, although I would argue not as high as it could be. People that used insulin, 94% of them were able to decrease or stop. So 60% were decreased their insulin by half, 40% were able to stop altogether. Fasting glucose improved by 22%, fasting insulin decreased by 43%. Lipid measures, so cholesterol measures, all improved or didn't change at all, and that's typically with LDL, which is a whole conversation in and of itself. Improved CRP, which is a marker for inflammation, and liver metabolic markers, all improved. The ASCVD risk, and this is a risk profile that cardiologists and family practitioners use to help determine what your risk is of having a cardiac event in 10 years, and that risk reduced by almost 12% in these patients. These are markers of insulin resistant that reduced significantly, 20%, 55%, depending on which one you measure it with. And A1C, of course, improved. So 20% at the beginning of the study with or without medications. And at the end of the study, 70% had an A1C less than 6.5. But here's the kicker, 60% remission. Now their remission, their definition of remission is a little bit different. They allow people to continue to be on metformin because a lot of people take metformin for other benefits as well. And so they allowed metformin, but 60% remission sounds pretty darn nice. So I'll talk a little bit about fasting. I could do a whole talk on fasting too. But fasting essentially is different from calorie restriction or starvation because it's all about timing. It's all about consuming calories when. So again, starvation is reducing calories chronically over the course of your day, whereas fasting is not consuming calories over a certain period of time, whether it be 8, 12, 16, 24, 36, whatever. There's different ways to do it, but that's called intermittent fasting when you have a set start and stopping point. And the difference between the two, you could say, well, what if I just took the average? It's the same darn thing. But that's not true because the hormonal response is different. And so you think of it like calorie restriction is like jumping off a 1-foot ledge 1,000 times. It'll take a long time, but you're not really going to hurt yourself. You're just going to be really bored. Versus jumping off of a 1,000-foot ledge one time, big difference, right? And so fasting is different than calorie restriction because of the timing of the nutrients and the hormonal response as a result of that. So studies looking at intermittent fasting demonstrate that your insulin levels will drop. Makes sense. Your basal metabolic rate actually increases, and that's the huge metabolic difference. VO2, which is a measure of your basal metabolic rate, rises, and that just demonstrates your BMR is going up. But that's the huge thing, and I'll talk about that with maintenance. The huge thing that your basal metabolic rate goes up with fasting, whereas with starvation it goes down. Fasting also improves your glucose, insulin, and glucagon levels in a different study. And this study actually also looked at a fasting arm to a carbohydrate restrictive arm and found that fasting was actually superior to carbohydrate restriction, although I would argue that maybe you could use both. So if you think from a historic standpoint, when we did not have civilization, fasting meant something totally different then than it does now. Fasting meant that you had not only a food shortage, you had no food whatsoever. And a food shortage was a crisis, and a crisis needs some kind of a response. So that hormonal response should not be like it is for starvation. It should not be your BMR slowing down, you're getting cold, you're getting tired, you're going to curl up in a little ball and not feel very good and not be able to think very well. If you did that when you were a caveman, you would die. If you're going to go out and fight a woolly mammoth, you need adrenaline, you need to maintain your muscle mass, and you need to maintain your basal metabolic rate. So it makes sense from a historic standpoint. And if you look at ketones, and I'm not going to talk much about them, but ketones are it's a fuel that your body can make when you're burning fat. And if you look at ketones when they're infused into the human body, they're actually protective of inflammatory conditions. They preserve skeletal muscle mass, and they prevent lean muscle loss during inflammatory conditions. Another study that I looked at demonstrated that leucine levels, which is an amino acid, leucine leucine are actually shown to be associated with maintenance of muscle mass, and that when you are in nutritional ketosis, your leucine levels actually go up, and that's probably what prevents you from metabolizing your muscle when you're fasting or when you're in a carbohydrate restricted diet. Excuse me. From a dietary fat standpoint, I think I've probably beat this up enough. Dietary fat is not associated with an increased risk of heart disease or stroke. It's been proven over and over and over again. It's what you're eating with the dietary fat or the particular type of dietary fat. Again, that's a whole talk in and of itself, but just rest assured that their dietary fat is not necessarily bad. There are some people who don't respond as well to it as others, but ultimately we need dietary fat to fill in the gap that you're going to leave if you reduce protein to where it needs to be for your body, and if you consume carbohydrates and at what is likely your carbohydrate tolerance level, which will be likely lower than where it is now. And if we don't agree with that statement, you can at least look at a couple of studies. So this is a funny study looking at eggs that showed a reduced risk of diabetes by 40%. Full-fat dairy reduced the risk of diabetes by 60%, lowers inflammation and increases HDL, or the theoretical good cholesterol. Daily nut consumption reduces heart attack risk by 35%. Why? Because fat does not promote insulin secretion. Fat does not cause insulin to go up in your body. And this is a study that was published looking at randomized control trials, and it just says very, very clear that the evidence does not support the current dietary fat guidelines. So this is a study, and others were included, that helped to change the dietary guidelines in 2015. So what about maintenance? There are lots of ways to lose weight, right? Like you can lose weight on a Twinkie diet or a candy corn diet. You can go on The Biggest Loser and lose weight, but it's all about maintenance of weight loss. And maintaining lean muscle mass, I think, is the key to maintaining your weight loss, along with some other things. So again, fasting not associated with the risk of weight regain. Why? Because you maintain your lean muscle mass. Carbohydrate restriction increases your basal metabolic rate. Again, maintaining your lean muscle mass. Understanding your carbohydrate intolerance level, I think, is critical. This is where I think people go off the rails when I talk to clients or the coaches, and people say, well, I've done the ketosis thing before, and I got into nutritional ketosis, and I I didn't feel like it was sustainable for me. And for some people, they just don't want to live that way. But not everybody needs to be in nutritional ketosis. Understanding your carbohydrate tolerance level means that there is a certain level of carbohydrate that you can consume and maintain your body weight. There is a certain level that you can consume and continue to be social and eat the things that you want to eat. But it's different for everyone, and no book is going to tell you what that is. That's something that you have to play with and work with and monitor your numbers regularly. Being metabolically dynamic means that you can burn both fat and carbohydrates. It means that you can choose which fuel you use. You can burn fat just as effectively or more effectively than you can burn glycogen. Maintenance weigh-ins, that's part of the PhD program for maintenance. It is absolutely critical. People that are successful come in and get their numbers, because it's hard to know when your weight creeps up. It's hard to know when you've gained a pound or two. It's easy when you say, well, I think I put on some weight. Gosh, I gained 60 pounds. But maintenance weigh-ins will catch it early, figure out what's happening, turn it around, and then fix the problem. And then collapsing the visceral fat mass. We didn't really talk about this at all, but the visceral fat mass is what that central obesity is. That visceral fat is communicative. It is hormonally responsive. It gives you cravings. It gives you hunger. It wants to get fatter. If you collapse that to the right level, those cravings, that hunger goes away. So the rules of reversal. Number one, carbohydrate tolerance. You got to learn what it is. Avoid fructose. I didn't talk about that at all because it's another talk in and of itself. But you find it is in sugar. It's half of sugar, sucrose. It's also added into a lot of food products. Just don't eat it. Don't eat it. Avoid refined carbohydrates. Those are things that comes out of boxes or bags. Enjoy natural fats. They're delicious. They're wonderful to cook with. You should eat them. Eat real food. Again, if it comes out of a box or bag, probably not real food. Use hormonal diet tools. Fasting is something that could be played with. Carbohydrate restriction is something that should be played with. Not everybody needs to fast. Some people find it as an excellent tool. Some people don't want to mess with it, and that's fine. Ultimately, it's about figuring out what works for you. And again, there are people locally that can help you with that. It doesn't have to be with PhD, but I would urge you to seek help from someone. All right, so any questions? Okay. Well, thank you so much for showing up. And again, this will be posted, I hope, on our website for anybody that didn't get a chance to actually log in and watch it. We look forward to doing these hopefully more frequently. And if you have a recommendation for a topic, we'd love to hear that. So if you're a PhD client, you can reach out. Or if you're not, you can always email us on the PhD website. That's phdwl.com or myphdweightloss.com. So thanks again so much for showing up, and you're welcome.